Hello, everyone. Welcome to New York. It's our pleasure to welcome you to the cardiac cath lab at the Mount Sinai Hospital, and it's our pleasure as a team to welcome you to the second peripheral case that we have the pleasure and honor of doing for this program. To my right is my partner and the director of Mount Sinai Morningside for endovascular, Dr. Vishal Kapoor. Behind me is Ray Lascano, our endovascular nurse practitioner. To Dr. Kapoor's right is our fellow extraordinaire, Dr. Osman Jaffer, and then Elizabeth Holton, our nurse, and we have Habib, our tech. We thank them for getting everything ready for this case. It's actually quite a challenging case. It's a case that's pretty exemplary in terms of our teaching points will be, and hopefully we can contribute to making your approach to these cases a lot more easier and also well thought out, which I think it will. So without further ado, I'm going to have Dr. Jaffer present the case to you so we can get started.
Thank you. Next slide. It's a 70-year-old hypertension. She's got paroxysmal AFib. She's a diabetic, hyperlipidemia. She's a smoker, CAD, multiple PCIs. Here is claudication, progressed to rest pain in the left lower extremity, rhetoric category 4. Her ABI on the left is 0.67. She had a recent intervention on the right side. And an ultrasound shows an SFA total occlusion on the left. In January 21, she had a left SFA proc Zilver 6x140 and the mid a Zilver 6x660. And then she has a long supera distally of 55/150. Next slide. This is a picture of her, here's an iliac angiogram, very slow coming up over here, but you can see she's got a patent stent in the left external iliac and absolute pro, and then a patent right in iliac as well. And her runoff here, you can see a very long segment CTO reconstituting basically the proximal portion of the popliteal artery with really a two-vessel runoff with a posterior tibial occlusion and an AT and a perineal that are going all the way to the foot.
All right, well, fantastic. So we have this case. So Dr. Kapoor and I just took some pictures. You can see this is the intervention that was done before, not really that relevant. Iliac, you saw, was done, but this is really what we want to show you. Our partner, Dr. Karthik Guja, who's the associate director of our program, is here as well. You can see here we chose a 7 French sheet because obviously it's an ISR case, and I think it's a good thing to do, go to sheath up a little bit to be able to have the options to do different products, which we'll talk about. So we just to read the angiogram to you, the little bit of plaque of the common femoral, it's nice stump occluded of the stents. As you know, there was Zilver PTX as well as the supera. You can see here that the flow to the is it going to work or is it me?
No, hold on.
Sorry, it's probably me.
It's working.
Yeah, so you can see here the profundo fills very, very rapidly. The stents are down, and it's a full metal jacket that was performed. Next. And you can see that the full metal jacket at the above knee pop around 10 is where it ends, right at that spot, and there seems to be reconstitution. And the runoff is 2 vessel down to the foot. And you can see here it was got a healthy AT, a healthy perineal. Next, please.
Mm-hmm.
And then the PT is occluded for a long segment and comes back at the level of the foot. And next, please. And you can see here that you have a beautiful arch that's formed by the AT and the DP, and you can see that the PT does fill very late through the arch, and you can see right there the lateral plantar. You can see in the medial plantar as well. So now Dr. Guja is also joined us. So Dr. Guja, our plan is going to be to do a standard cross. So this is a patient who's failed both DCB and Zilver PTX, the both drug-eluting stent options that we have at the time when we did this procedure. She's been maintained on medical therapy. She's been actually put on a claudication therapy with silacizole, has been walking, but it remains limited, and that's why we brought her back after 2 years of trying that. So now the point would be is what can we do to clean this out? And first up, we could just talk about what we're going to do. So how would you guys cross this lesion? And I'll just briefly describe what we're going to do. So we're just going to go with a support catheter and a glide wire and cross the lesion. Maybe you guys can talk a little bit about what are the pitfalls and what are the problems you can get into.
Right. So I think it's a good point brought up by PK about first determining what size of the sheath you will use. The 7 French sheath gives us a lot of flexibility in the form of visualization while using devices, as well as using multiple modalities. So you'll realize that if you use a 6 French sheath, then it becomes harder to visualize, especially if you have stencils like putting it in. But a 7 French gives us an option of visualizing, taking multiple devices, bigger luminal, like let's say if you want to use a directional atherectomy, you could use that. If you want to use aspiration thrombectomy, then bigger catheters like penumbra and all the other catheters can be used as well. In regards to crossing, I'm sure Karthik is going to talk about it as well, but if there's a nub like this, which is more favorable in this case, we start with an 035 system up front. Sometimes you'll see us using an 014, 018 system, depending on how the anatomy is, if it's flush occluded versus there's a stump or not. But as you can see, PK is crossing with an 035 catheter as well as an 035 wire, and we are through the stent. So so that becomes very favorable as well.
Yeah, so one of the things, Karthik, obviously we want to look for stent fractures. So maybe you go C minus. We did a dry cine for you to see what the mechanism of failure might be. Maybe the next one.
No, it's going to play.
Yeah, so here's we're just doing a quick cine run. These are the Zilver PTXs. You can see a little non-expansion there, and this is the Supera, heavily calcified vessel. As you can see, why we use Supera. Supera is pretty well deployed.
Correct.
And you know it's a long segment, so that's where it kind of comes back around 10. So there's no stent fracture that I see. So this we have to
restenosis, right?
Right, it's just typical restenosis,
and also
right?
the way your catheter is going, that gives us an idea of how much amount of thrombosis is there, along with.
Well, I am having resistance, Karthik. I want to tell you that I am pushing pretty hard here and pretty robust. And sometimes it's easier to just go with the catheter than to go with a wire, just because your wire may get under the struts. So all I'm doing is just gliding the catheter with the wire leading me, and I'm noticing when it's getting caught under the strut to pull the wire back and just torque my catheter and just push it through. Because it's more unlikely that a catheter is going to get under the strut than a wire.
Yeah.
So don't get worried too much about pushing these catheters. These catheters are quite flexible, and we're just using an aqua tempo. At this level here, I'm just going to have Vishal do a quick road mac. Our creatinine is okay. Okay.
Injecting.
I just want to make sure she's okay. All right, she's okay, guys. She's just sleeping, and just letting you know that she's not in any pain.
So I think it's a very good point where we have to always be careful that I'm not behind.
Okay. Okay, can somebody talk to her, please? Make sure she's okay.
Yeah, like we're not behind the stent strut, which is, I guess, a very important determinant of the success or failure of a case. So like Pika was talking about, using a stiffer catheter, sometimes looping a wire can help.
Huh?
It must be the injection and the cramp on the, color. Yeah, heat.
Just a little bit of heat that she's feeling. Mejor?
From the injection.
Yeah, it's probably from the contrast.
Can somebody talk to her, please? So what we're going to do now is we're going to go. We're just trying to get the loop down and break through the last part of it. Let's check the stent up top, guys. I mean, our sheath. Maybe I'm pushing too hard as I'm doing this technique. Nope, we're good there. Sheath is good. And we're obviously right through the stent struts here. So this is the area, maybe like Dr. Gu just said, is the glide wire time. Yeah. So maybe you guys can give me the glide wire now. So
it's over here.
Make sure it's wet.
So Karthik, now what are some of the, like, you see that it's obviously severely restenotic, unlikely to be thrombus, right?
Yep.
So what if the wire, tell me your algorithm if the wire flies through and has no resistance at all.
I think that's why I think you were trying with the catheter. I think when Dr. Krishnan was trying with the catheter, I think if the catheter just goes through directly without any resistance and you don't have to manipulate the catheters, that's most likely telling you that there's a lot of thrombotic component. Along with every restenosis, some restenosis component. But here it looks like there is a lot of restenosis, especially with the distal cap, like Dr. Krishnan is trying. Now we know. Normally, with every restenosis, there is some kind of a chronic thrombotic component involved in it. There are pockets where there is some thrombus, which is formed over time. So, depending on how your catheter goes, like if the catheter just flies through, you want to choose an aspiration catheter technique. You want to use an aspiration device. But in this kind of situations where you have a lot of restenosis along with thrombotic component, you want an atherectomy device which can debulk your stent along with aspiration component, preferably, or probably have two devices which do. You can use any technique you want, preferably one which can do both at the same time. So I think just like Dr. Krishnan is having now, I think now he's just entered into the pocket.
Good.
nicely. So
Okay.
that's a beautiful way of showing how to enter into a pocket. And you have a distal cap which is very, very thick.
Yeah,
Yeah.
you're right, Karthik. This cap is very thick, and so now we got good blood flow. So now we're just gonna now what you saw the two vessel runoff, Karthik. Vishal, what are your thoughts now in what you're gonna do before we go ahead? I know our algorithm is very set
Right.
here in Sinai. We've done it numerous times in live as well as in other areas.
And I would say, PK, even if there's a 3-vessel runoff, in this, when you have instant restenosis like this long of an instant restenosis segment,
Oops, sorry.
you would probably definitely want to put a filter,
Right.
no matter what, because there's always some thrombotic component. So you definitely
One-
don't want to take any kind of a chance.
Yeah, I think, absolutely. Karthik, like talking about, it's always a combination of the way the catheter, like Pika's talking about, the way the catheter behaves gives us a good idea of the thrombotic burden. Of course, in addition to presentation, the thrombotic burden of the lesion itself. So, like PK and we all published a paper for use of filter and what cases we use the filter in, and this is one of the indications is long CTOs, calcified segments, one vessel runoff is where it's indicated or should be used for using a filter, and that's why we're going to try to use the filter as well.
Karthik, out of the filters that are available, what's your algorithm for choosing a filter? Obviously, we published a paper on the algorithm and Jack Interventions for choice of filter, but out of the available filters, how do you choose? Because they're all obviously excellent filters, and I know we've made a decision here, but I'm curious on what your choice algorithm is about.
You don't want the
No, I
roadmap?
want to shut her in.
Oh, sure. I can
If,
give you a
if it's a
roadmap.
short segment thrombotic component and the vessel size is very large, I usually go with Medtronic filters, which are spider filters.
Yep.
You can go with a large filter, which is you can go up to 7.0 if I'm not wrong.
Right.
Filters. But if you have a long segment component like this with a lot of instant restenosis where you think that the filter will have a lot of movement and the vessel size is between 5 and 6, the popliteal size is between 5 and 6, you want a filter which is independent of the wire.
Right.
Like the wire can move, but the filter that way. First of all, I don't know if there's a lot of difference in the amount of thrombotic burden you will feel. I think both filters will catch the filter burden, but I think the radiation burden you'll have by constantly checking the filter place is going to be less.
Agreed. So you like the ambush shield for these kind of lesions?
Yeah.
For this kind of long segment lesions, and spider usually, which is the two most common filters which are used for us outside. So in peripheral space. Unless I don't know any other filters. Do you know?
Well, there are other filters. There's a Virion filter and other filters that, less uptake, like you said. It's not a major filter. So what Vishal and I and Karthik are going to do now for everybody is IVUS. Look, unlike the coronary space, the definition for IVUS is, or the defined utility IVUS is very well defined in the venous space and is getting more defined in the arterial space. So as you can see, there's a Jack Interventions paper that came out about a couple of months ago, I would say maybe end of last year.
Right.
And the Vishal, sorry about that. And the Jack Interventions paper showed there was a better patency associated with IVUS use with DCB than not. So we're just going to run this IVUS, and I want you guys to watch it. Can you play with the gain a little bit, Karthik? Can you ask them to just? Yeah. Oh, that's better, right? That's good, right?
I think that's good. We have the
Okay.
plaque and everything.
So record, guys. I'm just going to do a slow pullback from the pop all the way back, so you can see. So here we go with the slow pullback. So you see how diseased the outflow is, But you cannot get into vessel beautification, and that's why we kind of talk about this.
1 second, PK. We're going to change the depth. Can you go to 24? Please change it. Stop recording.
And start again.
Do the picture adjustment, please.
I got it.
Yeah. Go all the way. Yeah. Diameter 24. Keep going all the way. That's good.
That's good.
I think 16 is fine. Perfect. Okay.
Do you want the chromoflow just to see within the
stent? Yeah.
Let's
go chromoflow. Stop. And part of the advantage of our IVUS here with Volcano is that you have chromoflow with good flow within the stent. Okay, play again. Start.
So this was the CTO segment. Okay, start recording.
So we're at 10 already. Let me go down below.
Yeah.
Record.
Okay, start. Okay, there's your chromoflow.
Yeah.
So as we come, we know that this is going to hit the occluded segment.
Correct.
You can see there's a little flow in and around with the collaterals, but you can see the amount of plaque burden that we're dealing with. The plaque burden is just so high in the endovascular space, especially in ISR, as compared to, this is not ISR, this is just plaque. This is distal. You see calcified fibrocalcific plaque with no flow in this area, which we cross. But you can see we're truly within the vessel architecture as we're crossing this, and now we're inside the stent. You could see in the stent, obviously, the stent is crushed inward. Not really, but I think it's just the plaque that's there. And then as you see, we're coming back. It's just a completely occluded stent. With neointimal hyperplasia, I don't see any sort of anything that a thrombus or anything free floating that I need to be concerned about. So the IVUS, at least for me, looking at this IVUS, Vishal, what does it tell you? I'll tell you what it tells me.
No, I think it all shows us that there's mainly neoatherosclerosis, the neointimal hyperplasia. That's probably the precipitating factor of failure of the stent. And of course, there's extension of the disease more distally in the de novo or the native vessel as well, which probably caused the whole stent to eventually shut down.
There is some speckled plaque, and you can see there's some not so perfectly expanded areas in the stent, but that's probably the mechanism of failure. And this was obviously pre-shockwave. You can see right there, especially look how crushed that is. We're really gonna have to expand this.
Wow.
So we're just gonna pull back, and you can see again that part of the mechanism of failure is going to be the fact that the stent is not expanded well in the mid especially. So we're gonna have to do something. So obviously vessel prep is gonna play a role, or is it not, Karthik? That's it.
So I think
Stop recording.
I think three reasons of doing the IVUS. One is to know the mechanism of failure.
Right.
I think we already know now that there are some areas of unexpanded.
Right.
And to know if there is thrombotic component involved in it, which looks like there is some mixed, but mostly it's neointimal hyperplasia, as Vishal was saying. So I think the third one, I think, is to know what kind of device we want to use to treat this neointimal hyperplasia. I think we can purely go with the significant atherectomy device, which can do some aspiration component to it. And I think I would definitely do a vessel prep on this, but first I would probably do some aspiration atherectomy first, and then do the vessel prep. And I think there are areas where we might have to expand the stent, especially where there is a lot of calcium component.
Right.
So, and I'm assuming you're planning of probably doing some kind of a shockwave technology.
I don't know. I was going to talk to you about that, but let's first debulk this and then decide what we want to do. I am going to put a filter down now. I'm going with the EmboShield the way Dr. Guja and Kapoor described. I'm going to go distal into the pop above the
4-7 EmboShield.
4-7 EmboShield. Is it still? Do you see it or no?
No,
I don't see it.
Show me above.
Probably.
There it is.
Right
Okay.
That's the segment.
So we're going to go to 4-7 EmboShield
15.
and drop it probably a little lower than that. Probably right around there.
Yeah.
That's good.
Let's drop it here. And if you could focus on my hands, it's just a simple pull for those of you who haven't done EmboShield, and just deploy it like that. That's it. Now the EmboShield mouth is there. The wire is distal. So now when you talk about vessel prep, you said vessel prep, both of you. What's your choice of vessel prep and why? I mean, let's start with Dr. Guja, and let's go to Dr. Kapoor.
So first choice for here, I would definitely start the vessel prep mainly with the atherectomy device first.
Some atherectomy, okay.
Yes, definitely. And then I would use a balloon to create our lumen and everything. But the areas before, the final modality is what we have to choose is the patient has already had a DCB failure. So we know. So we have to decide what to do. We have to do with DCB one more time or anything. The final goal is what decides the third step.
Right.
Here. If you want to, if you're doing of DCB again and you think the primary failure here is because of lack of stent expansion, then we are going in the route the way of shockwave and then trying to do DCB again.
Real? Yeah. So we're going to get down there now. So Vishal, can you talk about the different atherectomy devices that are available, and then how do you what we've decided to choose is the Rotarex? But tell me about what else you could use in these cases. Not everybody has everything, obviously.
Right. So there are multiple atherectomy devices available. Since we're talking about ISR, essentially the real device which was actually tested was the laser, which is the only randomized trial for ISR, the XR ISR, which randomized patients with PTA versus laser and PTA, and it showed laser doing much better than the regular arm. Of course, we've used other devices as well, but there is directional atherectomy available where you can cut in different directions for your convenience. There is orbital atherectomy, but that's not indicated here in this case.
Neither is directional. Directional is
Right.
off-label as well.
Right, off-label use.
Yeah.
There's also directional with with aspiration as well, which we talk about as Rotarex.
Well, it's
which
not
is
directional.
orbital with aspiration on it, where it actually technically creates a negative pressure and aspirates in addition to doing its own atherectomy arm as well, thereby claiming to be decreased, distal embolization. So keeping in view the length of the lesion, the extent, the thrombotic burden, I think we have to consider all these factors before we decide on what we want to use. Usually, if it's very fibrotic, then I would probably go up with laser because you want to blast the fibrotic tissue off, make a channel lumen to get my balloons or whatever final therapy down. If it's more thrombotic like this, which we had certain areas, and most of the times the catheter was behaving well going down, I would lean more towards the aspiration aspect of my atherectomy arm and decide from there.
Okay. Well, so I think Vishal hit all the topics. I mean, all the thoughts.
We have
But
Jetstream
I
also,
mean,
so-
we have
Jetstream.
done all other modalities. We know Zilver PTX has the ISR study that showed that it works. We know that Impact has the Impact ISR.
Correct.
We know that DCB also has shown, but this patient has failed all the other. I want to just point out to the audience that the mechanism of failure really here is poor stent
Poor stent.
deployment. And I think it's going to be difficult to address that because of the fact that we've already deployed the stent. So we really need to now figure out how we're going to get this done. Obviously, there's a patient that we'd like to cure her as she sent to us for this recurrent problem. So I'm just going to, so we've got the rotational atherectomy here, what is it called? Our Rotarex.
Rotarex.
And some of the mechanism that I want you to look at is one, we've got the wire through, we've got the wire lock, and then we've got the flow bag, which is the most important thing with Rotarex. As we go down with Rotarex, it's phenomenal in cleaning out in-stent, and it has an indication for in-stent restenosis. In my humble opinion, this along with laser are kind of the go-to for ISR. Directional atherectomy is phenomenal, but it's off-label, and we don't want to talk about off-label things. The idea here is that this is a great device, and I think technique is important, and you got to make sure that you have flow. So we're going to get started on. So as we get started, very, very slowly, allow it to go through. Vishal will just pinch the bag. Notice the blood flow in the bag. As the blood keeps flowing, that shows that we are able to keep it moving. And if the blood flow doesn't come, then that's an issue, right? So you can see here a little bit of difficulty in working through. So I'm going to pull back and then trying to work through this area a little bit.
Back and forth.
Very, very
Pecking
difficult
motion.
to do.
Pecking motion helps.
A little bit more difficult, but we will be able to pop it through. And as it works through, we will know what's happening. And Karthik is going to keep kind of every now and then pinch the bag. You don't have to constantly pinch the bag, but every now and then just to make sure we have flow. We have had times that we've had to take this out and then re-flush it and then do it again, and which we will.
Especially with longer segments.
Especially with longer segment. But it's really worth the price because the price of admission is quite good. Is that you or us?
No, that's you.
That's us.
It just
It's
suddenly
every
decelerates.
time it decelerates, you got to be very, very careful. Walk with me, Vishal.
Mhm.
Yeah, you got to be just very careful when it decelerates, and it's very, very important to make sure that you're actually popping it through and doing it well.
No, that's you.
Yeah, let's just pull
Put it
back.
back, yeah.
I think we'll flush
Yeah,
it
I
again.
got
I think
Yep, it's coming. Okay, on. Ray, check that, buddy.
let me pull back a little bit.
No.
Mhm.
Okay, pull it back. Walk it back.
Stuck on there.
It's stuck. No, it's
No, it's
coming.
just slow.
Tight.
Yeah, I think it's just full.
There you go. Okay, let's walk it out now slowly.
So I think probably
Yeah, walk it up.
Sometimes it can get jammed on the wire, guys. Let's go to the distal wire. We'll look at it and we'll clean it out. That's part of it. We could always do laser if we need to. If we feel that this is maybe too fibrotic for this lesion, we'll clean it out. Get the laser, set it up just in case.
I don't know how frequently they're using
We can
Jetstream
flush
now.
it, yeah.
Jetstream also becomes an option.
Yep,
pretty much
we
similar.
still have Jetstream.
Yeah.
We can do it. So we're going to flush this out right now and go back
And
in.
go back in, exactly.
The other option is to do a cutting balloon, but I think debulking is important here, and the debulking will be very, very good for us to do. You turn it on. So we need to clean it out,
Hold this.
flush out the center lumen. You got
Yeah.
a lot of water going through there.
I think it's depending on how the suction of the tube is.
The what?
Tube.
The
also
tube
suction.
suction is what's determining its aspiration back.
Yeah, that's the problem though,
Yeah.
because the issue here is that gonna lock it. Yeah.
Yeah. Pull it back. Yeah.
Yep. So we're just locking it here.
Sometimes just flushing
Going
this,
back and
opening and
forth,
locking. Yeah, it's
Wonderful.
good now.
Okay.
Good.
Good.
There we
Good.
go.
All right.
Yeah.
Let's turn it
Good.
on.
That's perfect. We're gonna go back. Let's take a little picture to see where we are.
Mm-hmm.
A little die, guys. So you can see here that it's a challenging lesion, like we talked about, right? It's a very, very challenging lesion, and you can see here still, okay, a little bit better flow, right? You're getting a little
Yeah.
bit of flow, but again, we're
a
just gonna have to
channel.
keep going from that point on and just go slowly. This deceleration is a real problem in the sense that you have to be very cognizant of it. So it's an expected thing that's going to happen, and the 8 French Rotarex actually works really well as well.
Yeah.
So this is the 6 French we're using, right?
Mm-hmm.
Yeah.
Yeah. So rail and pull
I
it.
got it.
So we're just gonna go distal. That's fine. Right there is good. No, I'm good there.
Got it, Vishal?
Got it. Yeah.
So we're gonna go down a little bit more. Okay.
Went in smooth.
Yeah. Let's pull back here. Okay.
Mhm.
Start here. You lock the wire.
Yeah. It's locked.
So Karthik, talk a little bit about when you choose
Yeah.
laser.
So I think the option is, especially when I think people always think laser is used more for thrombotic components, but that's not true. Even if you have a lot of restenosis, you can consider laser, just like we do. A laser is a great option. I think we do it here. I personally also agree with you using Rotarex here only
Yeah.
because I still feel like it's a long segment,
Mm-hmm.
and there are areas where your catheter went in a little
One
bit
second, I don't
reasonably
have any.
smoothly. So I think there is
It's okay,
thrombotic
it's
component.
moving nice. Just pinch it. Yep.
Yeah, but if the order of deceleration happens here, I think laser is a great option. Especially the 2O laser is very good to be used here, which creates very nice. So
So
I think
let me ask you this: what if you had on IVUS or angiographic or fluoroscopy determined that there was a stent fracture or an under expansion? Would you still use Rotarex in this case, or would you change your strategy?
I would probably change my strategy to laser. I don't know what PK would. PK, I think it's not sucking.
Yeah, no, it's
Off.
not something.
Yep.
That's what I'm
Not
saying.
sucking.
We're almost done. Let me just go quick.
Just wanna make
I think we're almost done. So we just have to get it down slowly.
sure. Got it?
As you can see, it's you have to be confident. Go through slowly.
It's not doing anything.
Going down really
PK, I would
smoothly.
not.
No. That's
would
But
not.
it's okay.
I would not
still,
do it.
It's still doing it. It's still atherectomizing, believe me.
Probably not. Yeah.
It's still doing a good job. This part is going to be really hard. I know because our catheter had trouble going. Okay, off. Let's walk it out. And let's do it again. Show me distal. You're coming out with it
We are
on?
good.
Yeah, you don't need to come out with it on.
Yeah. Hold on. Slow. Don't.
Uh-huh. No, stay here, Karthik. So you just want to watch the distal wire as you come back.
Let's
You don't
stick-
want to move the filter, right? And we're going to clean it out again.
Hold on. It's stuck to the
Uh-huh.
wire. 1 second.
No, it's not stuck. It's coming out.
Yeah.
It's coming out. There you go. So what Dr. Kapoor is worried about is that the device is stuck to the wire, which can happen. And that's why you want to make sure
Okay,
it's not
should
too
be out.
gummy. So here now we're taking out. We're going to clean it out again. And we're going to go again. This is the price you pay. It's a long segment lesion, guys. And so when it's a long segment lesion, a little bit of patience, a little bit of good stuff as we go through.
I got it. Go.
Here,
So-
Go.
hold this.
What are you looking at?
No, just trying to make sure the suction is tight enough.
Give me a
Yeah,
second.
it's good. It's good.
Yeah, it's good.
Just flush it. That's
Yeah,
all.
go flush it.
You just need to flush it. Pull that out, please. Yeah.
Mm-hmm.
So it locks that. Now flush it. Just let it go all the way through and it'll suddenly start moving. See? That's exactly. Now, till it clears up, just wait. So it's starting to clear. See, if the audience can see the bag, you can see how the bag is now clearing. And the blood is now flowing. So that's good. And you just got to pinch this like this and keep pinching it till you get fluid out. See?
Even sometimes
That's
this
all.
works.
Now you got it. See that? Now you're clean again, and we need to go back to the distal and continue and finish up.
Yeah,
So it's a little bit of patience, but it's worth the patience because you're going to see the result. I'm not going to come outside the stent with this. I'm just going to stop at the internal stent, and then we're going to talk a little bit about how we're going to treat that, and then we'll take it from there. So now here comes the Rotarex out. Any questions? Can I have any questions from the audience at all? Do we have anything?
I'll give it to you.
Do we have an iPad like I was promised? Or thank you. I appreciate it. Nothing so far. Wonderful. Thank you. So we're gonna go down now. Let's go a little bit further.
Got it?
Can you just show me distal? I'm fine with
Yeah.
this.
Okay.
I can just do it by feel here.
Okay.
I think we stop right here on 30, I remember. Just checking on my filter. You know, this is the problem with these long segment devices, that you have to really check on your filter, check on everything, and then go.
Okay.
Okay, hold on.
Close it.
Yep. Ready?
Ready?
On. Walk with me, please.
Press on it, contact. Yeah. See, now it's aspirating.
Well, it doesn't usually get caught on the stent strut, as you can see. So I'm just pushing it
But
through.
Vishal's question is valid, Dr. Krishnan. If there was a stent fracture, would you still use this device, or would you choose laser?
I'd be very careful.
Right. I think we'll probably avoid those
We'll probably use the
zones
laser,
or
right?
areas. Yeah.
Laser is a great idea.
Yeah.
And you're right at the edge. Yep. You're outside now.
Yep, off. Great. Save that, guys. Let's walk it back. So we're just going to walk it back now. Push the wire, please.
What's the wire? What's the wire?
Wire's back. Hold on.
I know.
Just switch on and.
Nope, it's good. It'll go. There.
Yeah.
Okay, that's good. Just walk it back now.
Yeah.
Stay there, Carter.
Stay there,
please.
Carter.
Yeah. I'm just trying to take the slack off.
Hold on. It's stuck under the wire.
It's not stuck. No.
No, it is.
Okay, hold on. You see your redundancy. Hold on.
No, but I just want to make sure it's not.
Laura.
I got it.
Yeah, now it's better.
So again, this is part of the issues. You just got to be careful. I wouldn't push any further. There's
No,
plaque
I'm not.
there.
I'm not.
There's plaque there.
Yeah. I don't think it'll even go.
Yeah.
Okay, good.
I think it's just stopped there.
So now we're going to do a quick DSA. So now that we're done with this aspiration,
Bleed a little bit.
we're out now. Okay. So let's do a quick DSA. Make sure the filter is not
Just
full.
bleed a little bit. Side port.
Inject. So you have some
have
flow.
some flow from the.
Anti-grade flow.
You
Right?
already have anti-grade flow, which is
That's very
excellent.
nice. And the filter looks
And
good
we're
as
going to
well.
go low mag here. All right, here we go. There's our
There's the
Rotarex.
channel right there.
So we have a nice little channel that the Rotarex
Amazing
created.
how much it sucked out. See?
Yeah, pretty good, right?
Yeah.
Yeah.
And no embolization. So now the question is, how do you want to prepare this? You can see the Rotarex did a very good job. So the question is, how do you guys want to prepare this? Do you want to use a shockwave to expand? Do you want to use a cutting balloon? I think we have to expand this. We can go with a high pressure balloon, and then let's talk a little bit about what you think your final therapy should be. Because to me, actually, let's do an IVUS now.
Yeah.
Let's do an IVUS. Let's see what the Rotarex
I think
accomplished.
especially that area, which calcified area,
let me
you
just
might have to shockwave it to expand it. I don't know if the high pressure balloon will.
Yeah, but the question really arises is, remember what we talk about supera and ballooning and how it affects it. So if you use a shockwave to increase the compliance or elasticity
The
of the
only
vessel.
question is, can shockwave improve a non-expanded stent?
Correct.
That's my question.
So I mean, it's adventitious. It's supposed to break the adventitial calcium. Right?
Correct.
That's the whole question. But here it looks like the stent compression, stent expansion. I think is not because of the intimal calcium, but basically adventitial calcium.
So it may work.
So this might be a good case for shockwave to be tried.
All right,
Because
guys, get us a 6.0
The reason
shockwave.
is,
Actually, get us a 7.0 shockwave.
I mean, patient meets the criteria for reline, right? So technically, as per the reline study, you can reline the whole.
well,
stand
that
with,
was going to be our. I think this is not our final therapy, obviously.
Right.
We're still in vessel prep.
Right. But
and
if
then we can talk a little bit about what our final therapy
What I'm trying
could
to say
be.
is, even if you want to do a reline, you still have to have some kind of an expansion areas.
Right.
If you feel like there are going to be areas where the stent is unexpanded, you still can't reline it.
Right. So
I
think-
totally agree. Okay, so here's our distal.
So I think the issue is the reason
go
for
on.
under
On
deploy.
record, guys.
Right. So the reason for under deployed
7.0,
stent is the
7.0,
calcium.
7.0,
So I think that's why it helps.
Yep.
Sorry.
Go ahead. Let's start. Okay, record. Okay, pulling back. So you can see here, I'm going with a bigger shockwave, Karthik, just because I want to get as much
Luminal gain as
expansion as I possibly can. You know, with Supera, we're not going to be able to expand it any further. But the question is, have we debulked it enough in this situation? And it's always impossible to debulk the entire stent, you know?
Correct.
So the idea would be is whatever our final therapy we decide to do, we'd like to debulk as much as we can.
I mean,
of
also
this-
you can use
of
an
this-
atherotomy balloon.
Yeah, we could use an arthrotomy balloon, or we can just use a regular balloon, you know?
Right.
So I think we'll talk a little, since we started
this part.
area right here. We have
That's where
to
the
shockwave here.
overlap
This
is
whole
right there.
segment we got a shock. Oh, look at that right there. All that calcium. My goodness.
Yeah, I think that's the problem.
That's the problem. That's
this
why it didn't
stent is what-
expand.
Yeah.
So I think oh, look at this. So whoever did this, it's obviously not ideal in terms of how they did it. But the Supera was deployed properly, but maybe an undersized Supera might be a 4.0 Supera
Yeah,
for all
probably.
we know. So you can see that the beauty here is from the IVUS. This particular device, the Rotarex has done a great job. And you saw the patients that myself, Dr. Kapoor, and Dr. Guja exhibited in terms of not pushing that all the way down. So now we're going to go ahead. We're going to take the shockwave down. And how many pulses do we have, Vishal? Can you talk a little bit about shockwave, you and Karthik, in terms of how many pulses you have? You know, obviously you don't have a long balloon.
Right.
So how do you do it?
So this shockwave usually comes in standardized size. They go all the way from below the knee. They have a 3.0, 4.0, 3.5, and they'll go up to 7.0. Right now, they're probably coming with a bigger one as well. Usually comes in 60 millimeter length. And they have 300 total cycles, and every cycle is 30 seconds. So you can do 10 cycles per catheter length. So after these 300 segment complete, technically it becomes no more useful. So the idea is try to gain as much length as you can based on the shockwave. So sometimes in these long lesions, you might end up using 2 of them. So again, the economics part of it is, I guess, PK.
Well, that's why I think Karthik and I did the IVUS, because we know that the area we want to hit.
Correct.
I think the
Exactly.
proximal Zilver is just in
okay.
hyperplasia.
Correct.
So we're okay with that. We know we can deal with that. It's a question of where the stent is mal-expanded, which is where we're trying to expand it with the shockwave.
Right.
So Dr. Guja is going to look at our wire just to make sure that's a good spot to be.
And I think you want to hit the distal part of that.
Yeah, I'm
stented
just
area.
going to go
I think,
down.
yeah, distal to mid 1/3
Distal
segment.
to the stent area also, I think it's very calcified when you started off outside the stent.
Yeah, sure. Absolutely.
So that I'm pretty sure we are going
Well,
to
actually,
stent
since
that
it's
area.
so big, why don't we just go with a regular shockwave in the stent, because I did oversize the shockwave. So let's start here rather than take a 7 outside.
Right, I agree.
Right? And then let's go. So Karthik, can you tell us about what pressure to go up to and all
So
that?
the standard thing is we go up to 4, right? We wait for we leave the shockwave for the cycle and then go to 6. I mean, technically you can go to any pressure high up after that, but you want to go to 4. That's the average balloon length, and then create your cycle. Once the cycle is complete, you can go up on the pressure and then come down again, and then do the same thing again repeatedly. It's the same thing for any shockwave, both coronaries and peripheral. So
And
Down. I'm going to pull back a little.
again, the goal here is not to balloon. You have to take another non-compliant balloon after this to expand the stent, but the goal here is to basically create an axial calcification crack,
no, it's just the butt.
so that your non-compliant balloon can expand the stent, right?
Yep, exactly. You can see how nicely it's expanding there as we're going up.
Yeah, outside the stent, right
It's
below
a-
the stent, there is a lot of calcification.
lot of calcium.
Lot of calcium.
But he's
We
using a
started off-
7.0, so he's just
No,
a
it's
bit.
okay, right? We're going to
gonna
stent
cover.
that area anyway, so
Yeah, I
you
think
have to
that's how we
stent it.
should-
You
I
cannot get
agree.
away without stenting it outside the stent.
Yeah,
But until
just
that calcium goes,
right there.
that-
That's
that-
it.
that-
That's it.
Come back.
Come back.
come back probably a little bit.
A little bit more. A little bit more.
Yeah, that's
Perfect.
perfect.
That's good.
Yep.
'Cause we're
So
gonna
we're
stent
just
that
we're
area.
prepping the vessel outside the stent as well. Okay, there you go.
I did like.
For like maybe a Dorado or something. 6.0, I think. Yeah.
Yeah. You want a 7.0 long or 6.0 long
What?
balloon?
I would go to 7.0 long Dorado. Down.
Mm-hmm.
Down. Let me just come back a little
Yeah.
here, and we go up again. Go up here.
So again, if you think like you're not getting the most amount of usage for the shockwave.
Mhm.
I think the best way is wherever the
Shed it.
underexpanded area is, you want to put that in the center of the balloon. I think the most amount of
The
impulses
emitters,
happen,
right.
yeah, amplitude happens right in the center of the balloon, the middle two dots.
Hmm.
Okay, down. Yep.
200. Okay.
Now we're going to come in the middle of the.
I would do one more cycle there.
Right here.
We'll come back.
I think this is the real segment where it's
Yeah,
very
This is the area we really
densely
got to crank
The
it.
calcified.
filter
Yeah.
retrieval, if you have
Yeah,
it.
you
Go
can
to
see
10.
that like
Yeah,
it's,
So we're going to really be aggressive here, guys. We're going to go high in the shockwave balloon.
as Dr. Krishnan said, it's probably a smaller stent size.
correct.
And that's how it looks like. Looks like below it's almost like a 5.5,
5.5.
and that one is that middle superior looks like it's 5.0.
Or 4.0,
4.0.
right? That's why I'm just going to do the supera. This is the area that I know, like, get the overlap here.
Right there.
Go up.
Hmm.
Yes.
Okay.
What are the advantages of using image-guided IVUS endovascular treatment versus traditional treatment for ISR in the left SFA?
So what are the advantages? So repeat the question for those in the audience. What are the advantages of using IVUS-guided angioplasty versus traditional angioplasty with traditional techniques? Go really for ISR. So I think I'll take that one. I think the first one is that you have the fact that you're able to actually maybe predict why this thing went wrong. I mean, we're all pretty experienced interventionalists, and we all really feel that the reason the stent has gone down is really because of a undersized or mal-deployed stent. And I think it's mal-deployed because the IVUS showed us mal-expansion of a lot of the stent, especially a napkin mal-expansion in one particular area. So the idea here is going to be really to blast this, in my opinion. Go up again, with the go high,
Yeah.
and then really just try to figure out how we're going to do it. Am I going to perf? It's possible I could perf, but I think that it's going to be well controlled in our hands. We have the expertise to manage it, which we will. And I think we'll figure out how to deal with it. So for me, IVUS is that down. It's going to tell me how this stent failed if I can't find an obvious stent fracture. And two, it's going to tell me the morphology of the plaque. Is it fibrocalcific? Is it calcified? Is it thrombotic? Do I need to do a additional sort of therapy in this plaque to be able to help it expand and facilitate my continued success? I don't think sizing matters here because we know this is the problem is it's mal-deployed, and I think that's more native vessels. Vishal and Karthik, anything you want to add?
No, I think that's
perfect.
Yeah.
perfectly said by PK. It's just knowing what the etiology is will determine
Go up here.
what your treatment would be.
So I'm going to go really high pressure here within the stent. I'd really want to expand this distal. Go, keep going. Okay.
It makes a big difference because if you don't do IVUS, you would have never recognized that underexpanded zone.
Yeah.
Because angiographically, it's a 2D by 2D imaging, like we're doing it now on angiography, it looks like it's a well-expanded stent.
Yeah.
It's just that because it's in three-dimensional view, unless you do IVUS, you're never going to know that.
That's true because here you're right. Supera looks well stacked, so it's not like it's elongated, which is probably one of the causes of supera failure. But in this case, it looks well stacked enough. So I guess the undersizing is the
And also,
biggest factor.
the biggest failure for DCB, PK, correct me if I'm wrong, is recoil, right?
Yes,
Recoil is the
30%.
biggest problem with DCB failure. So that could be the reason why DCB failed on this patient before.
Yep, absolutely.
It's because it's an underexpanded stent, and I'm sure there's a lot of recoil in that area. So if you
yeah.
prep this, you might get away with just DCB therapy this time.
I agree.
And you don't
No.
have to relapse.
I think it's already failed, though.
Yeah.
I mean, we'd have to really convince ourselves that you prepped it. I'm not that convinced. I don't think we're going to be able to really expand this. All right, ready for pressure is good. Okay, ready for DSA?
everything.
Inject.
We still
That's
have
nice.
to hit that.
Yeah, we're going to send that anyway.
Yeah.
So,
But that's
all right. So now what we're going to do is we're going to take a picture up here to see
And
what it
re-IVUS.
is. Okay, inject.
much better.
Much better. All right, give us a 7-0 now. 7-0 Dorado. Let's see if it goes.
I know.
We'll try our best.
You want to do the proximal end with this?
With the shockwave, we're done. We used all
We used all this. We
Bang for the
got
buck.
bang for the exact.
7-0 Dorado, guys.
Yeah, we have it right here.
What length is this? 200.
200.
I think we should go. We've prepped it enough with the distally, especially.
So we'll do the 7.0, and then we're going to run the IVUS again to see whether we got the improvement that we desired. And I'm going to keep this within the stent, guys,
Yep.
because we're really going to go high
Agreed.
pressure here.
So the idea now is to really do the PTA action, like you talked about, not using shockwave as a pure PTA device, but in this case, just expand the stent as well.
Let me show me.
Yeah.
I'm just going to watch my distal wire here, and it's going to be what I feel in my hands. So I'm going to go very slow and just watch as this. It's ISR, so it should slide through, which I'm praying it does.
I got the wire.
Okay, mag up with the distal, guys. So you can see the Dorado, which is a great balloon, but a very difficult balloon to sometimes that's going to stop there. To sometimes deliver because of its bulkiness, it's going to help us. So obviously there's a chance we might perf. I want everybody to know that our intention is not to perf, but to expand this. So we're going to go up here really high pressure, but that's why we're using a high pressure balloon, right?
Yeah.
So Karthik is going up here.
Wow, look at that.
Ah, yes.
Sedation.
Which is what we expect that her to say. So what level are you?
10.
10. What's nominal in this balloon, guys?
8.
Okay, go to
So you,
12.
we can actually see the dumbbell appearance. We can
Yeah.
see the proximal and the distal
Okay, that's good
expanded.
right there.
But
Well,
the
we know that
unexpanded.
definitely that's going to expand a little bit better than here, right? Down? Okay, okay, good. So we definitely went up with a 7.0 balloon to 12 atmospheres. So we are prepping the vessel the best we can. And you can see the proximal is definitely better expanded, especially at that level where it was kinking. Remember, guys, that right there? So it's definitely better. So now I'm just going to come back with this. Well, you can go further. It's already expanded. I mean, there's no. I think you're just giving a pain here for no reason. You might as well get. You already expanded that, right? Yeah. It's not a tapered balloon.
We can actually see from the expansion of the balloon how differentially it expands. So the lesion length and the under expanded segments. Right there.
Go in, Ray. Go in, Ray.
Go in.
A little more. No, Jimmy.
The sheet is coming.
Okay. No, I don't want it to come outside. Let me see.
Yeah.
Okay, go up.
Yeah. Yeah, that's the proximal we had.
Okay.
Yeah, that was the segment we didn't hit with the shockwave first. Wow.
Beautiful. So now you can see the expansion.
Yeah, I'm going to fluoresce.
All right.
Okay.
Good. So Karthik, I know, is expanding this very nicely. And now we know it's expanded very nicely.
8. I went 8.
So it's 8,
I'll
go
go
to
a
10.
step down,
Just go
yeah.
10. Yeah. Okay, we're at 10 now. Okay, down. All right, now we got to go double negative and triple negative.
Yeah.
Any questions over there? Wait, it's got to come down, yeah. All right, so we've very aggressively prepped this now. And now what we're going to do is we're going to decide what we're going to do. We're going to go back and IVUS this and then decide.
Fluoro.
Not down yet for sure.
It's down.
Good. Wait, let it come down again. Let it do one more time.
Yeah.
So we're going to go ahead and IVUS this. Oof. Okay.
So what is the wire?
Get ready, Ray. Help me.
Yeah.
Fix the shit, buddy.
Push.
So we're coming out very slowly here. It's a very bulky device because of the pressure of the balloon and how good the balloon is. So now we're going to just go ahead and re-IVUS this after taking a picture. Okay, Dr. Guja's got it now. Yep, it's still in. Guja's coming out. Yep. So we're just going to make sure we didn't perf.
Should be out.
Okay, ease it out. Yep,
Right.
you're out, Ray? Okay.
Okay.
We're going to just leave it on the one in case we perfed. Ready?
Ready.
Inject. And this is where you can embolize too. I've embolized at this level too. So there's the outflow, which we have to fix. We know that. And we're going to go ahead and look at proximal.
Great.
Very nice.
Certainly better expansion.
Mhm.
Now we'll take a look now with the IVUS, and then we'll talk a little bit about other therapies. Hopefully now we'll get the good expansion of that particular. You can take this, Braya.
Yeah, I got it.
Thank you. We'll get good expansion of that area, and then we have to talk a little bit about the outflow and what we want to do in the outflow. So now we're going in with the IVUS. So we so far have had no embolization, and so the intravascular ultrasound is going in. So Karthik, are you happy with this? Yeah, I know that you weren't thrilled with the 7.0, but I just wanted to really expand it. Hopefully it worked for us. I know we can't guarantee that this is going to be any better, but I think it will be a little better for us. But angiography obviously is not the best way to assess this. So let's go in with the IVUS and just look at the stents now. We've not looked at anything else. I just want to look at the stents to make sure that we've expanded and don't really have any areas where the stent is very poorly expanded. So as we come down now,
Looks much
we're
better.
coming. Okay, just to about here. Start recording, guys. This is just at the distal stent edge. And as we come back, stent definitely looks better expanded here. A lot of plaque like we talked about. Look at that. That's
Wow.
really pretty.
Beautiful.
We really were able to expand that supera much better in the distal with a 7. And there's a little area of malexpansion here, but we can hit that later.
Right.
And then we're coming. And this area, again, you can see there the level of plaque, but the stent seems to be better. And again, look at the stent again, very well expanded. But again, some areas
That's
of
the
plaque protrusion.
The overlap looks much
Overlap
better.
looks better.
Oh, definitely.
Yeah.
better.
And this again is the calcium. That looks a lot better. And then at this level, looks a lot better. And we know the Zilver was always looking good.
Right.
So Zilver has always been very well expanded. So now with this, the question is, do we need to
Stop
do
again.
anything further? Let's take a picture of the distal, and let's capture our filter and decide what we want to do distally. Yeah, let's take a look at this shot here.
Mhm.
Ready? So this is our distal.
No, filter capture device. Oh, yeah.
So we have a large collateral there. So what do you want to do here?
Yeah, for the supera part.
Yeah. Inject.
Yeah, the question is here,
What is it in the Zilver?
probably like a 7. We'll see. Oh yeah, definitely. This needs to be treated.
So what do you want to do here? So the question now is we've got the distal lesion, which is our outflow. Do we stent it? Do we DCB it? What do we do? I mean, I think here we could stent it with a good stent. And the question is, you want to use a Zilver PTX here. What are the advantages of the Zilver versus a Supera, so on and so forth. So Karthik, what do you want to do with this distal area? Maybe you could check maybe you could check the IVUS
It all
distally.
it all depends on. I mean, we have to stent it. That
Right.
doesn't change. It all depends on what do you want to do for the proximally. The Zilver looks like size is 6.0.
Right.
So we got a 6.0 lumen on the proximal.
So what was?
Silver area.
But that's fine. But let's deal with our outflow now. So outflow wise,
I would use a Supera here.
You'd use a Supera here.
Or Zilver is fine actually at this point of time. I mean, we didn't do DCB here much.
No,
So I think Zilver is a great idea here.
but we didn't use
point of
DCB
time.
anywhere.
No, I'm saying assuming that if you plan to do DCB on the top, which is probably not, but I would probably put a Zilver here.
Okay,
Well, yeah, I mean,
I like that.
That's what
Give
I
us
would do.
what size? What does IVUS tell us as the size and length? What is our IVUS size, guys?
We didn't go distally to the level of the
Yeah, we did.
Yeah.
With the first run.
7.0.
7 or at
Or
least.
you want no 7 or no? Check it with the IVUS.
IVUS.
So look at the first run, the distal to proximal.
No, he's saying the first one.
So for the audience, we're trying to decide how we're gonna do, but let's prep
This
it
is the
first. So guys, give me a 6.0 40 or 6.0 60 balloon, 014 regular balloon.
He has to go.
So I'm getting an echo in my. Oh, that's because Dr. Guj is outside. I got it.
Mm.
Okay. So we're just gonna go ahead and get a 6.0. Yep, 6.0 is good.
6.0 vessel.
6.0 is perfect. So 6.0 60, a regular balloon for me. 6060 or longer?
That would take an 80.
Give us an 80, guys. Whatever you got.
Yeah.
That's fine. So we're just using a vessel prep balloon because our plan here is to use the Silver PTX for the distal outflow.
Size is 7.1.
Yeah, that's what I'm saying.
That's your real vessel size.
So this
of the Popliteal P1 segment. So
So yeah, it looks 7 angiographically. So you can put a 7.0. Silver, you always want to upsize a little bit anyways. So probably do a 7.0.
For the audiovisual team, we're having a lot of echo in our ears. Thank
You
you.
want to take the filter? No, not right now, right?
Not right now.
After this.
Oh, filter came back. Okay.
That's what I'm saying.
So what I'm doing now is just going to go ahead with this balloon and just balloon this, and then we'll decide on the descent. The reason I don't want to put a silver 7 is that it's now going to go ahead and come into a 6 or a 5 balloon here, Supera. So let's give me a little die here. Let's make sure that we cover the distal. A little bit further.
Yeah, a little bit further down, right at the branch.
Yep, a little bit further down. So I'm going to go down a little bit further.
Right up
Okay, let's balloon there. So we're going to balloon this. This is a 40. And then we're going to balloon this with the next one. No, that fixed it for us. Yes, thank you. Yep, the question?
What are the potential risks and complications associated with image-guided treatment for ISR of the left SFA?
So there's no complication really associated with IVUS. Obviously, down you have to. The question is, what are the risks associated with image-guided therapy of this SFA? There's really no complication that can be associated with it. Your anticoagulation strategy has to be sound because obviously it can cause you to have thrombosis, like any device within the vessel. Go up there. Any device within the vessel. So I don't think there's really anything there. So now we're just down. We're just sliding by here. Okay, go up here. Go up. Slow.
Slowly, yeah. 4.
Down. Let me go a little across it. Now go up.
2, 4. I think we got it.
6, 8,
10, 12.
10, 12, 14. Down. Damn.
Wow.
Wow. A little bit of oopsie daisy there. Go up again.
Okay.
14.
14.
Okay, we're up 14 atmospheres here with the thing. I think a 6.0 is the right stent. Down. Okay.
Okay.
So we're going to come back.
choosing a 6.0 stand.
I think so, brother.
Mm-hmm. A 6 or 60?
Yeah, so 80 or 60 or 80, whatever you want.
80? Sure.
Let's take a
Do a
look.
little bit of overlap. Yeah, sure.
I don't know if overlap's a good idea here because it's going to be
Yeah.
undersized. Oh, oversized.
Silver.
Okay.
6 or 80 silver.
I don't think 80. Let's take a better picture. Ready? Cindy?
You have the wire? Yeah.
So what are we doing for the proximal stem?
Well, let's take care of the outflow first.
Yeah, I think the outflow first.
You have to go from almost 15.
Yeah, 15 all the way up.
Even 80 is not enough. 80 is like up to 7. 15 to 7.
All right.
80.
So give us a 6080 silver then.
80 is barely making it.
We have to cover up to 15, looks like.
Yeah. Well, 14 is enough.
14.
So the question really arises is the silver in the adductor canal. Are you concerned about anything?
Well, that's a great question. The question is about stent fracture.
1.4%, right?
Huh?
1.4%.
1.7 after 3 years in the Japanese PMA study.
Yeah.
There's one outlier of the Silver PTX that talks about high stent fracture rates of 5%, which has never been reproduced in any other trial. So I'd certainly throw it out. It's pretty much around less than 2%. Obviously, Illuvia is a great stent. So talk to me a little bit, Vishal, about the Imperial trial, Illuvia versus Silver, where obviously Illuvia was superior
Right.
and also reduced mortality.
So it was a head-to-head randomized trial comparing Alluvia stent to Zilver PTX with 1 and then 2-year follow-up, which actually 3-year now, which actually showed better patency results in the Alluvia arm as compared to the Zilver PTX arm. So
No, it was better patency at what 1 year.
1 year.
year.
One
But
year.
the results
And
are
then-
out for till
Yeah,
3 years.
yeah. So I think at 1 year there was better patency, and
what I
obviously
thought as well.
obviously the at 2 year there was a equalization. There was no difference. There was a mortality difference at 1 year. So I think that obviously I think it's dealer's choice here. I think
Right.
you have good data with both. Obviously Zilver
Got it.
has out to
Got it.
5 years. But
Correct.
again, it's very small numbers of patients.
The
So I
follow-up
think there's a
has
big
lot.
argument on which one you can use. But I think, drug-coated therapy is drug-coated therapy. I think if we prep the vessel well here, I think the reason for failure is not going to happen as well. So I think we'll be okay. So we're just going to go down with this. And we're going to deploy this. I just hope it's not too long.
Let me
But
hold my
we'll
wire.
see. It's okay. I think it may be too long, boys. I told you.
No, it's good.
It's
15.
too.
15.
I mean, you have so much overlap.
That's what I was thinking, 60.
Yeah, I think 60 is a better stent. All right, guys, get us to 60, please. This is too long. This is way too long. Because you want to be right past 15, right? I mean,
Yeah.
to me,
Right
right
past
at
15.
15
So we're
is
still
where
not at 15.
Oh, you're still not at
Still have a
15? You
look.
want to
Yeah.
go? Hold on, don't
That's
open.
good. That's good. That's it.
All right, then leave it. Okay, I agree. Karthik's always right. All right, go up. He is. He always is. Go up. All right, Flora. And we're just going to deploy this here. Obviously, the filter is going to move a little, but we have nothing in the filter, so I'm not worried.
Good spot. What's your overlap?
Yep,
That's
that's good.
enough
That's
overlap.
perfect now. Yep. So we're just watching to make sure we get a little bit of overlap. There's our 6.0 stent, and we're going to IVUS it to make sure it's well expanded.
Pull back, pull back, pull back.
Beautiful. No, it's
Nah, you're
beautiful.
fine.
Beautiful. Okay, excellent. All right, Baya, walk this back now. And then save that. Flora, save that.
Yeah.
So remember, so for those of you who say we're burning a bridge to bypass, this is already a disease spot. So we're not messing with anything where they can do a bypass if, God forbid, she develops CLI, which I doubt she will. She follows with us quite closely since we've been treating her for her claudication. So I think what we're going to do now is we're just going to go ahead and now make sure we IVUS this and make sure it's expanded. But we'll take a picture. Let's capture that filter, guys. Let's get the filter capture device.
Got it?
Uh-huh. Okay, out. So we're going to quickly take a picture. Low mag here by you. And then we're just going to make sure we didn't embolize anything or dissect anything. Okay. No, low mag the other way.
Oh, look. Sorry.
Uh-huh.
See the stent.
Okay, that's good. Ready, inject.
Some junk in it,
Yeah.
a little bit.
It's okay. What's
Yeah.
that? Who's asking a question? That was it. Okay.
Liz has questions.
Yeah, there is some.
Liz has many questions.
Very little,
Dr.
though.
Krishnan.
Okay.
You think it's a lot? I don't think it's a lot.
It's a reasonable
You can
amount.
see that.
But it can be captured.
Oh,
I
it
think
can
if
be
you
captured,
partially
yeah.
capture
Yeah,
it,
yeah.
I think it's good enough.
Okay.
Probably like half full.
Yep, I agree.
No? Ray's nodding the head, so
He's agreeing.
he's not agreeing.
Is this?
He's agreeing.
I don't think it's full. Yeah,
No, it's like half full.
we're gonna be okay. So you want to take it up to the proximal dot, and then you just want to pull the filter wire back, and just
That's good,
do
that's
a
good,
half
that's good, that's
capture like that. Maybe a little bit more than that, like that. And then you just want to come back as a system. No, it's opening up. So we'll just capture a little bit more. I think in this situation we may have to lose the wire.
It's
We
fine.
should be follow it. So you want to make sure the filter doesn't come off. If it does, then we have to deal with it. So this is like a
Fine, I
half
mean, even if you
capture
lose the wire, you can
kind of
revive it.
situation. So, okay, we got it in there. Okay, good. No. Is it out? No, I think it's stuck inside our sheet.
Hold on. Flora?
Come on, Flora.
Yeah.
Nope, it's
Nope.
out.
I think it's probably out, no?
No.
Nope, it's there.
Right there.
Stuck right there. So we're gonna pull
So
it
the
back.
wire is, yeah.
To lose the wire, which should be okay for us.
It always happens at the arch. Where the
Okay,
takeoff.
let's check that filter. Bleed back. Flush forward, guys.
Mm-hmm. There's very minimal, not that impressive. There's a little bit
Okay,
right
good.
there.
Give me a
Always
command
pretty
wire here.
Yeah.
Okay, now we're going to give some
Throw this.
command to O1A, please. Uh-huh.
Sorry. Oh, that fell. You okay? Just I missed it.
A bit lower.
Jack.
Mm-hmm.
My only worry is always with the wire doing all that funny stuff. Did we dissect anything? And thankfully we did not. A little bit of stenosis in the AT, which we might have to take care of. We'll talk
Probably
a little bit
spasm.
about that. Maybe spasm, like Arthur
Yeah.
said.
With the wire. It was
Yeah,
really
with the
kind of
buckling
pushing,
of
yeah.
the wire. Yeah. But distally
Nice,
looks very
beautiful.
nice.
Looks very good.
There a dissection at that box? Might
I
be.
think so.
Give us a wire, guys.
Where?
The Prox PT.
PT.
Perineal, I mean. Give me the command 18.
Mm-hmm.
So we're going to go with the command 18. Is this an 018 IVUS and 014 IVUS?
There's an
Okay.
no 014. Oh wow.
So, oh, give me a command 14 then.
Yes.
Extra support, please.
So
That was there.
That's how it looks like, right?
Yeah.
It was there.
Yeah. I remember like it was flow was like that. It was a little aneurysm.
Yeah. I know.
So for the audience at home, we were really talking a little bit about that osteal perineal. And you can see prior to, there was a double shadow there too. So it's not really a stenosis or an occlusion that we created. So we're okay with that.
So TK, now the plan is
Plan is to
Oops. Sorry.
oops,
Sorry.
what?
Sorry.
We-
the plan is to IVUS, and
My
then,
bad,
and
my
then
bad.
take it from there. So we're going to rewire this because we lost the filter. So we're going to go with this. And again, it shows how much use imaging has in these studies, you know?
TK, so I was to decide how would I was change your
Well, for me
decision?
right now is to look at that Zilver, make sure it's prepped well.
The proxim, the distal,
the silver that we
newly
just
deployed
put.
silver. He hasn't.
Thank you. So now, guys, tell me your final therapies. What would you guys do?
Looking at the Karthik, go ahead.
Yeah, no, just because you said DCB is already failed.
Yeah.
And I don't think we have achieved as much expansion as we are supposed to expand in that mid area. I would probably reline it.
Well,
This
the
point
only
of time.
question is with the reline, you have two different stent sizes, right?
Right,
You said you have a 5 and a 7.
right.
So the question is, do you go with a 5 in one, and then do you go with a 7 in the other? You know what I'm saying? I mean, a 6, 5 and a 6. So that's my only question, right? Ooh, where is this thing going?
Let's do a small
Little
test.
digest?
Yeah. No, I think you're right. I mean, if it was
It's probably
initially
a small
first time, I
lesion,
would have just done a DCB and see how it is if a segment needs anything.
I think there is a dissection, see?
I have another question.
Yeah.
No.
Are there
Nope.
any
No, it's just a branch.
Yep.
alternative treatments available for ISR and the left SFA? Are there any alternative treatments
Yeah,
available
take it.
for
Yeah.
ISR
That's fine.
in the SFA?
Well, I mean, DCB is one of the options which we talked about. If it's the first time long segment, ISR, we can put a DCB in if it's
It's fine. Leave it there.
right there. But since in this case, it's in a branch.
It's in a branch.
It's in a branch.
Yep, that's fine.
But because this is a recurrent failure, then you can have to talk
Can you give me
about
an IVUS, guys?
putting another layer of stents versus other aggressive options. And maybe if it's failure rate higher, then you might even go for bypass surgery. But I guess in my case, DCB as the first option for long ISRs to prevent a double metal jacket. And if that fails, then probably reline it like Karthik was talking about. Karthik, what do you think?
No, I got it. Depends. I mean, if I see a reason for failure, then I DCB it again. But here, I think, I don't think we're going to achieve anything.
Mhm.
The only problem with what Dr. Krishnan said is about reline of using two sizes is, how are you going to two size it? Like you have 6O silver in the bottom. If you put a 5O, Vibon, a covered stent, how are you going to achieve your central lumen? You're putting a 5 and a 6 now?
Or you can put a
Yeah,
6 and a
because
5.
yes, but
Yeah.
we already lined it with silver now.
Not this area. No, I'm talking about the
Proximal.
proximal. Oh, I'm not worried about this. Let's see the silver expansion. That's what. Let me go down first and look at the tibial.
Looks, yeah, looks
It
good.
looks
It's
just
just
disease,
disease.
but it's good.
Yeah, it's
It's just disease.
There's
Okay,
no-
can you record,
There's
please?
no record.
That's your area of concern, right?
Yeah.
Yeah, it's just
It's just
disease.
disease.
Oh,
No.
plaque, right?
Yeah,
No
yeah, all
dissection.
plaque, all
No.
plaque.
Okay.
It's clear intima. You can see the intima lining with no disruption. So there's no real flap there. It's just disease.
Now this is
or,
the silver. What we talked about expansion of the silver. I think it needs to be post dilated.
we're still down to 1,
Yeah.
2, 3, 4,
Get us a
5.
6015, guys. Via track.
Now here it increases. I think just at the distalmost edge.
But it's also elliptical. It's not circumferential.
Yeah,
Correct.
yeah.
Yep. So
Oof,
we got to
look
post
at that.
dilate this over.
Okay. Stop
6015
recording.
via track.
Well, I guess the biggest determinant in this case, especially when you talk about relining, is the outflow. If you have 1 vessel, 2 vessel, 3 vessel, that also, I think, in my personal
So-
opinion, determines if you can use a covered stent or not. Right, PK?
Well, I mean, the idea is, I mean, you know, if you feel confident that you took care of this and you expanded this, then that's fine. But to me, you've got 3 failures of drug coated therapy. Now you've done a good job of expanding it, right? So now the question is, you know, do you want to leave it? I mean, I'm not going to cover that distal collateral.
Right.
I've already got a silver distally.
Can you do a spot Vibon?
I
Like
mean, you
just
could
in
do
one
just
spot?
for the 5-0 and then just.
Yeah,
but I,
5 in the middle and then DCB rest proximally and distally.
I mean,
The
you
Vi-
could,
the
but I
Vibon?
mean, I don't know what you tend to gain by that. That's my point. I mean, you can reline the Supera with a 5-0, but I don't know. That I'm open. I mean, I'm open to anything to really think about. But
I think that's what I would probably do. I would just that
Unless
area
you
where
put
the
two
calcified
different-
vessel is
Go
put
up
a
here.
5-0 Vibon because it's already 4-0, 5-0 Vibon, crack it open as much as possible, get the maximal luminal gain, and DCB before and after the Vibon.
well, the problem is, see, the Vibon. The reason I'm doing the Vibon is to exclude the plaque.
Right.
See, you're not going to be able to expand this Supera with the Vibon down. The Vibon is going to stay whatever size you're gonna. The Supera, because Supera is not going to allow it to expand. So the question is, have you done a good enough job with the Supera? Go up now to reline it.
But we are
I think we
assuming that
have.
it's a 4-0
Okay, down.
Supera.
Yeah, I was
It's a 5-0. 5-0.
5-0.
No, I'm saying that's Supera you because we only got 4-0 in the lumen.
You have to, no, you said 5.
No, 4. So
Done?
can we show the saved frames?
Or I think you can do a graded version where you could put a 5-0 Vibon in that underexpanded stent
saved images.
and put a bigger
Base menu.
6-0 proximally because
And,
distally it looks good. We did an IVAS which shows this.
No, the one
plaque
before
has been
this?
taken care of.
Down.
Come down. Come down.
Go up here.
No, up. That one.
12.
4-0.
3-7 by 4.
3-7 by 4-0.
At the tightest spot.
Yeah,
At
yeah.
the tightest
That
spot.
was
Go up
pre-intervention.
again.
No, this is post.
Oh, it's post
This is post.
Okay, down.
We can use the same mode to expand proximally.
Yeah, that's what I'm going to expand the area.
Try one more time since
Yeah,
it's already there.
Let's go here and hit it again.
Yeah.
Go up.
Right at 25 is where we are talking
Yeah,
about.
yeah.
Yep, go up there.
Look at that. Still, you don't see the.
Yeah, you could see the dumbbell appearance like I was talking about. The proximal
Yeah,
and distal
yeah,
open up. 14, 16.
Go up.
Mm-hmm.
Right there.
14, 16, 18,
20.
20.
Down.
So all I'm saying is
22.
put a 5-0 from there to there.
Yeah, that's something step graded.
Down.
And as you said, like the plaque, of course you're not trying to get the plaque away. You still have the plaque here.
Okay, down.
Hold on one second. Fluorescent. Okay.
It's amazing how well it looks angiographically, but
Yeah, IVAS has another extra
Yeah.
set of eyes.
Mm.
Okay. Mm-hmm. Wow. That needs to be relined, yeah. Under expanded with some plaque protrusion.
from 30 to
Yeah.
almost
Almost
12
back to.
centimeter mark to almost like 150.
Just plaque.
This
Just
plaque
plaque.
protrusion, yeah. So we have to go 30 all the way back if you want to do it. I think distally, you like Karthik said, you can just do a DES, and from the proximal segment, you can
DCB.
size it to the middle segment and then just do it. But
The question is, do you want to? I think I would go all the way from 5.
okay,
I mean, it failed. It failed, right?
yeah,
Hmm.
okay, it washed off. Do one more time.
No.
Okay.
The question is, how is 5 making any difference from centimeter mark? Because from 5 to centimeter,
No,
looks
but it's
okay.
already it already reached notice
Yeah,
and
yeah.
included.
Right.
So if I'm going to exclude it, I'm going to exclude it. Only
Yep.
question is go with a 5 or a 6 is the question in terms of expansion. So give us a 60250 Vibon, guys.
The question, how did you come to a 6-0 conclusion?
To me,
6-0?
I think we can expand this nicely without infolding. I really do. So let's see.
Yeah, I think that's one of the biggest factors, the infolding in these stands. So
But even if you think that Supera is a 5-0, how would 6-0 give you any lumen?
Because I'd like to I'd like to go proximal
Proximal
and
to it.
distal with a 6 and cover those two. 6250.
otherwise, for
Because
sizing, what's your rule of
I know proximal, I'll have a problem. Distal, I'll have a problem. I mean, proximal, I'll have a problem if I go with a 5. So I'm going to go with a 6. I mean, this is obviously, a difficult situation because we're dealing with a stent that's already underdeployed, underexpanded, which you prepped well. But now the question is, what are we going to do? So I'm not going to touch the silver. I'm going to go to the Vibon. I'm just going to go across just up to maybe right at the level of the silver area and then take it from there.
I want to see where the collateral is coming from. That's
Collateral's
my
much distal. Much distal. Okay, that's it right there. Mag it up, guys.
Mm-hmm.
Approximately doesn't matter. We're so
Usually
far up.
250, yeah, should cover.
We're so far up. So see,
Yeah.
we got to put another one in. So I am going to reline this a little bit distal here. I think that's good right there. Everybody agrees?
Yeah.
So the thing with the Vibon is just pin and pull, and you can see here it's pinning and pulling. And I always tend to pull the wire all the way out. This way and then what I tend to do is not move my Vibon because the markers are pretty poor. So you can see right there is the distal Vibon. So it's right by 14. So I know where the last one landed. So now it's by 14. So now I'm going to get a. We're going to see what size we need. So 14.
7.
What size do you want? That's 150, huh?
Yeah.
Give us a 60 150, Mikey.
150.
Yeah,
60 150.
Exactly 150.
Yeah,
go from
we have to come
stent
up
to
to the
stent,
ostium.
yeah.
Stent to stent, yeah.
I think 150 is good size. Give us the overlap and the length.
And so as far as anticoagulation, what would you guys do now?
I would put the patient on Xarelto for sure.
Me too, 100%.
Guaranteed, 100%. I don't think that's I see 100% Xarelto.
Mm-hmm.
So we're going to IVUS after, guys, just to let you know how this looks.
The question, so you would put the patient on Xarelto 2.5 twice a day, or PAD dosing, or full dose?
No, I'll do
Xarelto?
2.5 here.
2.5.
I have 2 vessel runoff. I'll look at the flow after. I'll IVUS it. I'll make sure everything looks good. Like I said, she's a very good patient, Karthik. I mean, she's an excellent patient. So she will follow with us. I know she's
This
very
one's going up to
compliant.
proximal.
And I think I can definitely help her with this. So we're going to go here now. And hopefully this is the right length, which is what I'm praying for. It's a little too long, which is,
It's fine, I think.
I think that's fine. A little overlap. As long as we're not inside the other stent, I'm okay. I think that's good. And I think we're good there, guys, don't you think?
Yeah.
Let me mag it up here. I'm worried about the procs, right?
We want to go with test. I'll just.
Yep. Little die.
You can even
I
come back.
think
a
come
dot.
back. I'm going to come back a little.
Definitely come back a dot.
Yeah, hold on.
Because I don't think they nailed the ostium.
Exactly.
Yeah.
They missed
Last
the
time,
ostium.
I agree. So I'm going to come back
And
a
there's
little.
some
You want to
little bit of
roadmap it?
disease
Yeah, you can roadmap.
proximally as well.
Mhm. Sorry. Excellent. So we'll come back here.
That's perfect.
I think that's perfect, guys. What do you think? I'm gonna leave it right
Okay.
there,
Yeah, that's good.
and then
Good
you don't.
forward.
Yeah, I don't have to do anything. I think we're fine. Nope, leave it.
Shouldn't move.
Should not move.
Wow.
There you go.
Perfect.
Good. Perfect.
Okay. Fluoro save that.
hmm Okay, so now we're gonna walk this out.
Let me
Give
get
me
the
a
other.
6-0 long balloon, please. 014 long balloon. Walk it out, guys.
Mm-hmm.
Actually, do you have a 7-0 long balloon? 300 or something like that? That's fine.
Perfect.
So this part is very important, as is the IVUS going to be very important for us to really understand what's going on. So now I'm going to take this and the IVUS. Now, a lot of the purists will be probably a little concerned that we put a silver distal, but I think, there's no choice here. We have to. So, we did what we have to do. We knew that DCB would not tack that up because of the level of dissection.
Mm-hmm.
So we're going here with a 70200 Ultra Burst balloon all the way down. It's an 0-8 balloon. It's a very good balloon. And so we're going down. Obviously, we don't want to drag a fluoro, Vishal bhai.
Mm-hmm.
Yeah, sorry about that.
No, no,
Bhai.
you're good.
Okay, the wire
Watch
came
wire,
back.
wire.
That's
Watch your
fine.
wire.
That's
Watch
fine.
your-
That's fine. Just let the wire go into the silver.
Yeah.
Yep, hold it there. Right there is good. So we're just gonna. I don't want to dissect anything distal.
No, I know. I'm holding it.
Mhm.
Right in the silver.
Yep.
It's still in the zero.
Wait, hold
I
on.
got it.
It's not going.
No,
Oh,
hold on.
Oh, one second.
One second.
No. It's just.
No, Karthik, it's just
stuck
stuck
on this. That's all. Dr. Guju was worried we were getting stuck in the strut, which is a very valid point. So now we're just gonna go distal right there. Okay, good. Just get the overlap, and then hopefully we'll be able to smooth this out as well as we can,
Mm-hmm.
and then take a look.
Got it.
Thank you.
Go.
So she's gonna feel a little bit of discomfort. Liz, floor, please. Go to 20.
Mm-hmm.
6.
That's good right there.
It
Good.
has an overhang. It's a
Good,
7-0.
good.
Mm-hmm.
Very good.
The silver. Be careful with the silver.
That's very good expansion. That's fine. Yeah, we're good. Let's go ahead.
6-0 silver, right?
I know.
That's okay. Then let's get this part here. Flora?
Mm-hmm.
Flora?
It's all stuck on behind the arm.
Oh, I got it. Let me get it.
Got it?
Yeah, so
Yeah,
this way it's
thank you.
easier for you. You don't hurt
Yeah.
your
You
back.
can go crazy.
I'm going to just stop it right there. We'll hit the rest.
Oh, it's going out of the.
Yeah,
out
down.
of the stump.
Mm-hmm. 6 1 6. Mm-hmm. One second, let it come down.
Okay, go up now.
Good. Still 4. This takes time. 8.
10.
Mm-hmm. 12.
Okay, down. Get us a short 6015 Vitrac. I got to hit the ostium.
1 second.
If you have it,
Mhm.
use the same one. We got to get the
Yeah,
ostium.
one more.
Again, double negative.
Mm-hmm.
Okay, walk it out.
Mm-hmm.
So we have now expanded this. We want to just get that ostium a little bit better. And sometimes, it may not get better. And the Vibon's a great stent, but it's really on the operator to prep the vessel. And I didn't think I was going to go to the ostium, so I really didn't prep the ostium well. So hopefully this will expand and not leave a residual. Vitrac?
He's getting it.
Oh,
We
no,
have the
we
6
have-
right?
we
This
have
is
right
it.
there.
Oh, sorry. Yeah. I have the
6 O's right here.
Yeah, right there.
So it's in perfect shape.
Yeah, I think the biggest thing in this is to expand it very well, especially with the coverage tends to get good patency results and good outflow. So,
Exactly.
like you talked about, infolding is the biggest concern. So,
Yep. So we're going to mag it up with that
Mhm.
distal, guys, for me.
Yeah.
Proximal, I mean, excuse
Yeah.
me.
Okay.
And our concern is that we don't want to hang out too much, so we're going to come right in,
Put a
go
shoulder.
up here, by.
Got it. Oh,
So we're just going to go up.
go forward. Go.
That's good. 8, 10, 12, 14. Nice.
16.
16.
18.
Okay, good. Good. Down.
One second.
Perfect.
Fluoro save that.
Uh-huh.
Okay.
All right, Ivis now.
Mm-hmm.
Yodi.
Looks good. Open.
Let's get a quick Ivis.
Mm-hmm.
So now we're going to do another IVUS, and I think this is the discipline you need when you're doing these kind of reline cases to really do it properly. So the IVUS is going in. So we say reline case because it's the registry that obviously Gore had to look at ISR and patency with using Vibon in instant restenosis. So that's what we're trying to accomplish here is a good result with a coverage 10. And technically speaking, the restenosis usually occurs distal at the disease segment, which is why we use the Zilver. And hopefully that's going to be enough for us here to be able to hold this together. So as far as surveillance for this young lady, she's going to need a lot of surveillance in terms of oof,
Wire.
Is she okay, guys?
What's your wire? You have the wire?
I'm pushing the wire. Don't worry, it's fine.
Okay.
Is she okay, ladies and huh? Okay, good. So we're just going to go from the Zilver out. And ready? On. Record. So we're recording. So we're just going to look for infolding. There's the Zilver expanded, and there's the reline. I don't see much major infolding. Actually, it's quite good.
Mm-hmm.
Follow it.
Mm-hmm.
Very good. A little elliptical in that spot. Now we're going to get to the area where we're worried. It's actually quite good up to here.
Come up now.
There's the area we're a little worried. It's
Yeah.
small lumen, but it's not infolded.
Yeah.
It's not infolded, I can tell you that. Oh,
Right there.
right there.
Right there. One spot.
Right there.
Right there.
So show me that spot.
Yeah.
That's 20.
Okay,
22.
23, we have to hit it. And right
Right
there
there.
at the overlap.
And then it opens it.
Pretty damn good. Give me an 8015 Vi track, guys.
Stop recording.
So the audience at home, I mean, we saw pretty much two spots of it, what is it called? Infolding. So we're going to hit it with an 8015 Vi track if we have it. Do we have it or no? If not, give us a 80 Ultraverse, please, or an 80014 balloon. So this is you can't really call this pave and crack or crack and pave. It's probably more hopefully this is going to work with a higher balloon. But I'm just going to tack it up because I saw that we're obviously got this little amount of infolding, and then take a look.
Yeah.
That's fine.
I think I'll go through it. Yeah.
It should go
Yeah, I'll go. The proximal.
as we enter.
Yeah.
So any further questions on the iPad, anyone?
No.
Unfortunately, no questions yet. So we are going to go with the 80.
All right.
So it's an 035 balloon, and technically, as you can imagine, you want to be very careful, as Dr. Guja so nicely pointed out, in the proximal, you really want to watch it enter into the stent, especially the Viabon, until things get better. So yeah, exactly. You don't want infolding here. So far, we don't have any proximal infolding. We know that, but we'll balloon it again with the 8. All right, very smooth. And we know the area was, what'd you say, Carly?
22. 20.
20 to 25. Well, we'll balloon this whole area. Okay, go up with an 80. So now I'm going to be super aggressive. It's going to hurt. We know that. And we're just going to, allow it to hurt, but really try to expand this as much as we can, knowing that keep going. I'm going to go in a little bit too, Karthik. Okay, 12.
There's a little bit of waist distance
Yeah.
as well.
Okay. Okay, down.
Yeah.
Okay, now let's get it. Yep. 16, 18, 20. Okay, down.
It did that 21. It
Yeah,
expanded.
let's just try to keep going a little bit, a little aggressive here. Show me down. 20. Yeah, I pray. 20. We're going to 20 atmospheres with this. Really trying to gain some lumen here.
Just concerned with that outpouching right there.
I think
Yeah.
that's plenty, right, guys? We'll go up
Yeah, I think
top.
that's enough because
We'll
we
just-
have a little bit of outpouching on the
Yeah.
axillary
Well,
rectus,
we
so-
got our covered stent though.
Yeah.
Yeah. Go up here.
Mm-hmm.
The question is, it's only going to go to 6. The max. That's the max.
Yeah. That's it. That's fine.
Hold on, let me fluorescent.
Okay, down. And now the ostium. Let's try to nail it again. Go up here. So you can see the amount of work we're doing. I know it's a lot of work for the audience, but really try to get the best result we can down.
It's like doing a bypass.
It's a very good point.
It's an endovascular
Okay, go up there.
bypass. Right there.
I'm going to come back a little bit, Karthik Bhai. Hold on. You can,
Yeah.
but it's very tough to.
Come back just
I know
the
to come back
shoulder,
just
yeah.
a little bit. Yep, down.
Yeah.
Okay, go up now.
That's it. There it is.
There you go. Now you got it. Beautiful.
One second, let me fluorescent.
Okay, down. All right, very good. So we're going to take some pictures here, and we're going to go.
Wait.
Okay, watch the wire. Walking out now.
Mm.
So we're going to do step-by-step pictures. Just I'm going to tell Dr. Jafford that just is enough for us to fill Osman G. Just enough to fill, so don't give all the dye. So just enough, like 3 cc's per spot. Okay,
A little bit
good.
more.
All right, give us a little night pride, Liz. I want to hit a little more night pride. It's actually a very nice, nice stent. So we're gonna hit some nitro into this vessel, and
Yeah, now you can give the full thing. You don't have to do this.
okay, flush, flush. Oh,
I know you when you put the sheet, you
One
take
second,
it lower.
stop.
no, keep flush.
Always.
Yeah.
Pressure builds up.
Because it's not 14 is not.
Okay, flush, brother.
8 is more than enough. Because you're directly injecting into the vessel.
Okay. So we're just gonna do a picture here.
Yeah, we're good.
Okay, ready?
Yep.
Yeah. Very nice.
Beautiful.
Very nice so far. Up to CSI.
Very nice so far. Very nice. So, Dr. Krishna, how frequently do you do ultrasounds on her?
You know, in her for the first year, we'll probably do every 3 months, and then we'll take it from there. I mean, we're gonna see her in clinic regularly.
The area of 30,
Yeah.
right by 30.
It's a small.
Perf?
No.
No. It just
It's
looks
under.
very.
No, I think we got it. I think it's just sort of.
Could be the diamond also giving that effect, but at 30 it looks. It's good.
It's good
It's
enough.
fine. I think that's
I think
the.
the
Honestly, you
diamond
don't
was
think you
like
can get better than that.
Yeah,
You
I
know,
think we use an
we're
8
done with
balloon.
this.
Yeah.
So let's go down. Now, this is what we got to make sure our results are good. We got to make sure we don't close any vessels.
So 1, 3, 6, and 12 months.
Yeah, at this stage with this kind of patient, Karthik, we'll be very careful. Okay, ready? Inject.
Very
A
nice.
little worried about
No.
that spot, huh?
Oh, yeah.
There's something going on. I mean, it doesn't look
Come
like
back
it.
up. Let's see.
Let me go a little bit more lateral. Shut her in now.
There's some calcium there. So.
There is some calcium, but the wire was doing all sorts of funny things. Right? Inject. No,
I
there's
think
no
it looks good.
There's no
It's exactly
dissection.
the same thing.
There's definitely no dissection.
It's just too many branches.
Yeah.
That's why it feels like that.
The overlap of the branches gives that effect.
Now let's go to the foot. So again, you see how we're so paranoid about the distal vessel for us. We're really, what is that over there?
That's your
Ultrasound.
Oh,
ultrasound.
okay. No,
There's
it's
some
not.
bag there.
Some bag there.
Yeah.
Okay,
Got it.
good. Actually,
That should be good.
that's
Yeah,
fine.
that's
Good.
fine.
Good.
Okay, inject.
Wow, look at the robust fast flow through the AT.
That's definitely a cutoff. You see that?
Yep. That's some embolization.
That is some
Peroneal.
embolization of the perineal. So go to your first, and this is the discipline that you need to have with these devices. Obviously, seeing what's going on, you have to have good pre and post shots. So obviously, even though we relined and we did an atherectomy, we've got embolization, and we're going to need to deal with what we're doing here. So what I'm going to do is ask for a command wire. See, there's the perineal pre. It comes all the way down, and you'll see it here. It actually bifurcates at that level. No, that's still the AT. AT was always faster. Just a little bit. I think you're fine.
I think it's the
A little bit of
same, no?
spasm probably, right?
I would probably put a catheter there, give
Yep.
some medications,
Okay.
and then
Yeah.
probably.
All right.
Take another
Let's see.
picture through the catheter.
Yep. Let's get us a 014 catheter, guys. I mean 035, not 035, 018 Trailblazer.
Yeah. I mean, I agree with the plan. It's better to be cognizant of the
So you can see now she is the claudican, but we definitely want to leave our device, our lady, the way we found her. We don't want to make her worse because of our procedure. You know what I mean? So that's very, very important here. So I'm just trying to straighten out this wire here before I try to go forward.
Here, there you go.
We might have to use the catheter to
we
straighten
got
it
the
out, but that's
yeah, we
fine.
got- Here, just turn it around. Okay.
So the question, like going after this vessel distally, would you, because you're putting the patient on Xarelto anyways?
You could
So
argue leave it. I'm not saying
leave
no.
it because it's just a distal vessel, and in the process,
Yeah.
you might do more.
I mean, I think in our hands it'll be smart to do it. I think in somebody who wants to leave it, probably reasonable to leave it.
Yeah.
I think just a wire Fogarty may be enough here. To be able to get it done. But we'll take a look. Yeah, it's not going to go with that loop. We know that. Yeah, with that loop, it's going to be a
right
problem.
there at 24. Let me pull it back a little bit.
So we're going to go down with the 018 catheter. Mag it up for me, guys. Floor?
Yeah.
Uh-huh. No.
That's your branch. There's a bend which comes in the vessel.
Yeah, no, I see it.
That's
Right there it goes.
Again, a branch.
And now
See how it behaves. Go down straight.
follow it now.
Yeah. Nice.
Give me some meds, Liz, here.
Right. Oh, we were in the branch where it was going laterally, so. This is knife, right?
From Fogarty.
Yeah. There it is. Yeah.
100 nitro, 100 nitrite.
Yeah.
So you went into every single branch, Dr. Krishnan, just to wire it and just
Open it up. So.
Where's my catheter?
it's still there.
Still up there.
Oh, it's still up there. Sorry.
Yeah, right there.
Okay, so I'm just going to go ahead here and give my nipride. Give me a little dye, Ray.
Oh, this is knife, right?
Yep, and a little dye.
I'll give it a.
Give me a flush, brother.
That's the flush. Flush. One more die, I think. He's probably going. No. Good. Thanks.
So we're just giving medication, just like in the coronary space, in the vascular space, a lot of room for medications and doing the right thing in this manner. So I'm just flushing it through. Even though our wire wasn't down here, it was down here in a lot of different ways.
Die.
I think Karthik already injected, right?
Yeah.
See, it's already coming, see? So now I'll try from here. I think it's just spasm.
Yeah.
It's just competitive flow that you're seeing.
Yeah.
Right.
So that's always been there. So we're done here. So let's
Yeah.
just go and take another good picture, Karthik, for me.
Yep.
Inject from above. So that's so those at home. It's not filling that little posterior communicating artery because there's competitive flow through. See
Yeah,
how it's
the
filling through
AT.
the arch.
Yeah.
So
That's
that's
probably
all
also
competitive
preventing
flow.
that
So I wouldn't
transfer.
worry too much about this. So just now your arch is
completing your
filling and
flow.
everything is perfect.
Yeah.
So I think you're done here.
Mm-hmm.
Agree.
Just
Now
wanna-
your AT becomes a primary vessel
Yeah,
to the front.
yep. And I just take one more shot here just for my own health here and my mental well-being. And you can see here that I think it's beautiful. We're
Very
really
nice.
diseased vessels, but nothing different than what it was before.
Mhm.
So again, for everybody, we're about 15 minutes ahead of schedule with that, which I think is a good idea. Anticoagulation strategies, Karthik. You said Xarelto. Would you still believe 2.5 Xarelto in this case? And why? Because currently it's off-label, right?
Yeah. I mean, for this patient, I think with PAD, Xarelto, I think she meets the criteria for 2.5 Xarelto. Not for this, but in general also she meets the criteria for it.
Yeah, she has PAD,
Through the
CAD.
Compass
Yeah,
trial,
mhm.
she meets the criteria. So
Avoid your
I,
PAD.
on this patient, would personally give Xarelto 2.5 aspirin Plavix for a month, and then I would probably stop the aspirin and just put the patient on Xarelto 2.5 and Plavix.
And you
That's-
say aspirin Plavix for 1 month because of the silver.
Yeah, that's
What
it.
about you, Karthik? I mean, Vishal.
I'll probably give aspirin Plavix Xarelto 2.5, but I'll go for 3 months again because we put a DES. Usually do 1 to 3 months. Bare metal, we try to do 1 month again. But if she tolerates it and no bleeding issues, then aspirin
Yeah,
Plavix and DS.
I mean,
3 months.
I know we can do a bleeding score on her. Make sure that's good. I know Osman is very conscientious with stuff like that, and I think with everything actually, I shouldn't say stuff like that. And the whole point is, I think we'll do a bleeding score on her and either do 2.5, for at least 1 year or 2 years. But clearly, I think for her is going to be aspirin Plavix, 1 or 3 months Plavix with 2.5 Xarelto, and a close follow-up for the first year, both symptomatic follow-up as well as long-term follow-up. The idea here is that your Vibon doesn't have infolding. We actually checked that. We ballooned it with an 8. I think we got our result that we needed. And now we just leave it alone. We got good runoff. I think we just have to make sure the distal vessels don't get worse and occlude off, which then could cause this Vibon to go down hard. The worry also is the Zilver at the distal edge, because the Vibon is living on that Zilver, so we have to follow that Zilver closely as well. Can the Vibon itself go down? I mean, anything can happen. I think if she gets hypotensive episodes or anything like that, it could happen. But I think if we've got her well anticoagulated
Unlikely.
enough, I think she'll be fine.
Yep.
So, without any comments, Vishal, Karthik, before we sign off?
No, I think,
No, I
the
think it's
case,
a good learning case
very
for her to
learning case.
determine the therapy of choice, starting all the way from various atherectomy options, using other DCB, DES versus, or a combination of both, including covered stents. I think it was a great demonstration.
Yep.
so.
Osman, any comments on what your thoughts are here?
Oh, I think it was a great case. I agree. It went
okay.
really well. Yeah.
Okay, Ray, yourself, anything? All right.
Good.
Well, without further ado, we thank everyone who tuned in for this really exciting way of teaching, really 24/7. We all congratulate Dr. Mehta, obviously, for his foresight, Dr. Sharma for his foresight, and obviously Dr. Stone and the entire team for putting this together. We're really a pleasure for us to participate. We hope we've been helpful in contributing to your education. And please, we look forward to seeing you not only in MedStream 360, but also obviously with our CCC live cases that we do monthly. So I also want to throw in a shameless pitch for the New York Endovascular Summit, both the Fellows course as well as our main course. We do run the Mount Sinai Endovascular Fellows course in concomitant with the New York Endovascular Summit. This year it's September 23rd, 24th, and 25th. Dr. Gujo, myself, Dr. Kapoor, our entire vascular surgery team, our entire interventional radiology team, vascular surgery led by Dr. Ferries, and interventional radiology led by Dr. Lookstein are going to be there. It's actually a phenomenal course, and the Endovascular Fellows course, which is phenomenal, is associated with it. So we really hope to see you there, and we'll contribute in every way to your education. Thank you again, and we'll see you soon. Thank you.
Thank you.